So in terms of the objectives for today, gaming disorder and all the complexities that come with it is what I'm going to focus on for the first hour. So this would be looking at diagnostic criteria, prevalence rates, and other factors that are seen to be associated with it. We're going to go through some of the treatments that are out there and research opportunities moving forward as well. And the second half, and we'll take a break in between, would be looking at low-dose naltrexone, which is essentially a different use of regular dosed FDA-approved naltrexone, and it's used for really a plethora of diseases and medical conditions out there, and pretty fascinating stuff that I think is pretty interesting, and what else we could use it for, and I think how it's going to garner a lot more attention moving forward. So just some basic stats. Over the last 15 years, there's been at least, and actually I think it's more than now, 1,000% growth in terms of people using the internet globally. Revenue for specifically gaming in 2016 was almost 100 billion. We've jumped from 16.5 in 2015 to 36 billion. This was just reported for 2017. There's been a shift from kind of PC computer-related gaming to mobile gaming, which is now kind of one of the bigger markets out there. Stats in terms of how many game-playing households there are, and this is growing. And not necessarily in a negative way, because a lot of families are getting into this as well. But most households now have some sort of device, and then if you count your cell phones or your smartphones, essentially everyone's walking around with a gaming device that can be utilized in one way or the other. Gaming competitions are a big deal. They are worldwide. So the first Cyber World Games started in 2001 in Korea. They held it in San Francisco in 2004, and it jumped to essentially, it was over $200,000 in terms of prize money that was coming in when it went to Seattle. I believe that was in 2014. And so the amount of money that's involved in terms of gaming and professional gamers is exponentially increasing. FIFA Interactive World Cup, which is soccer or football everywhere else in the world, which is kind of one of the more hotly contested online gaming tournaments, and it still is at this point the largest one out there. And over 2 million people enter to play, and they essentially whittle down the number of gamers until there's a live final held. It was New York a couple of years ago, London last year. And it jumped again from prize money going from $20,000 to London, I think it was a little over $200,000. And so you can imagine how this is reaping benefits in multiple ways. The Evolution Championship happens in Miami every year. So multiplayer online battle arenas, or MOBAs, or what they call them, are huge. And so that's what the international is. It's people coming together to play a variety of fighting games: Street Fighter, Mortal Kombat, World Pump Festival. So dancing, I mean, there was a spike here in the US, and then it kind of maybe petered out a little bit. But in Asia, these dance festivals, per se, are still a really big deal, and people get really into it. I mean, there's synchronized dancing, there's speed stepping, pretty hilarious at times, but also engaging. Pokemon, so I mean, as opposed to a lot of the more mature adult-related games out there, so this is definitely intended for, you know, all ages. They do have, it's kind of cult followed, especially, I think Korea is probably one of the biggest followers. Pokemon Go, anyone remember or has heard of Pokemon Go, the augmented reality game, which was interesting because it got people, you know, up and moving, but it also got people, you know, walking into lakes and driving off cliffs and lured on a less humorous note, people then, ingeniously figured ways to lure people to specifically secluded areas and in terms of mugging and violence. And there was a recent study, they looked at traffic incidents and a spike right after Pokemon Go came up. It was over 100,000 that were attributed to specifically this, and people looking at their phones and either driving into people or inanimate objects. So, but the whole point of trying to get gaming and people more active was harnessed at that point. So I defy anyone not to get a warm, fuzzy sensation when you hear, classic platforms. So Mario, Donkey Kong, this is kind of the stuff that I grew up on as well, that led the kind of scene at that point. So this is Zelda, one of the older adventure puzzle games. So you're interacting with an environment. There's clues. It's really non-confrontational. You're not fighting against a clock. Lots of hours spent playing. So first-person shooter games, I'm going to throw this out there. Anyone recognize where this is from? Let's go for it. So that is Doom. There you go. It is Doom 1. So this was the pinnacle of first-person shooter games at that point. The graphics here versus there's a new Doom out, which looks insane. And we can get into the aspects of violence later. But this and Wolf 3D were some of the first-person shooters. This is Myst, I think in the early 90s, one of the highest kind of PC selling games out there. Again, puzzles, interacting with the environment. Gaming really took off with role-playing games. So these games derived their play from traditional like Dungeons and Dragons related games, and it opened it up to so many individuals across the world, kind of forming teams. League of Legends, World of Warcraft, these are the big ones that are out there and still dominates at this point the playing market. Simulation games, whether it's building, enhancing fictional communities, even controlling other lives, flight simulators, all of that kind of go under this rubric here. Sporting games are, from a FIFA or otherwise standpoint, are huge. And the benefit of sporting games too, with a lot of these task-based games, at some point you reach, you cross the level that you need to, and the game is done essentially. With sporting games, it's infinite hours of gameplay that's constantly evolving. Anyone hear of Fortnite recently? I just wanted to throw this in there. So it's being touted as the new epidemic. This just came out. It's kind of Hunger Games-esque, where they drop a bunch of players into specific environments, and it's last one standing. This is directed towards younger kids, so it's 13 and above. There's no gore. They don't show people, guts exploding and so on and so forth. But it's extremely, what they're saying is addictive about it is the variable ratio benefit. So it's not you almost lose, you almost win each time, and people find that they're kind of leading the pack, and suddenly someone's taking a sniper shot to the head. And so the ability to actually engage and the unknown of whether you're actually going to win or not is huge. And so kids across the nation at this point are kind of, they call them essentially zombie packs. They move from house to house, and whoever parents eventually kick them out, and then they kind of travel until they wear out their welcomes. It's kind of cartoonish graphics, bright. It's got kind of a wry sense of humor. Very kind of socially engaging, but parents are now finding it that they need to kind of really limit set on how much people can play. And I don't think that's the last that we're hearing from it. With gaming, and I guess aside from console gaming, and as I had mentioned with smartphones, everyone here maybe aware of the wily temptress known as Candy Crush, which, you know, hours can be spent, and you can see people, whether it's, you know, walking around trains, buses, what have you, but it's the extent of how it's far-reaching and how kind of almost brain-numbing it can be is pretty fascinating. And they specifically, so this was included in DSM as a condition for further study. So not an officially recognized diagnosis, but they set out criteria. And the idea was it wasn't just, you know, console gaming, but handheld devices as well. And this was the only one that they actually included, as opposed to exercise, you know, shopping, and a lot of other behavioral compulsivity related concerns. So, and without spending too much time, there's a lot of similarities between your typical DSM-5 substance use disorder criteria and so gambling disorder is the only behavioral addiction that's from a DSM standpoint recognized as an addictive disorder. Preoccupation or obsession with gaming, when you're gaming or you're not gaming, you know, negative affective symptoms when you're unable to engage, a buildup of tolerance, you need to play more and more as you essentially get further along the game. This is a hallmark sign, unsuccessful attempts to reduce or stop playing. We'll talk a little bit more based on time of just some of this criteria is a little nebulous, and there's really a lot of counterpoints that one could make against, you know, pathologizing gaming, but we can get into that later. Depending on what you have around you and what you're focused on, you know, kind of moving away from things that used to capture your attention and focusing then more on gaming, the lying, covering up of use, and this is, again, more prevalent or pertinent, I should say, with kids and parents trying to kind of enforce regulations on them, and then using it as a way to escape opportunities lost because of gaming. So this is essentially brand new, and it was a big deal internationally. So as of January 2018, the WHO, with the new upcoming ICD, International Classification of Diseases, they've determined that gaming disorder is an actual medical condition with, I mean, it's not as kind of honed in, I would say, as maybe the DSM had tried to in terms of criteria and limitations. But, you know, it's a 12-month period that they're looking for, and a lot of the similar things that we had just seen. This has been both lauded and hotly contested. There are a lot of camps out there that are pushing against this, then stigmatizing and demonizing gaming, that there isn't enough evidence that we have in terms of inclusion criteria and stratifying, you know, when does this become problematic. On the other hand, there are people saying, if it's not recognized, how are you going to get coverage? You know, how are people going to get treatment when there are, and it's from a percentage standpoint, which we'll get to, it's if we're looking at, you know, global population, it's not everyone, and it's a small percentage, about 0.5 to between 0.5 and 10. But for those folks, this can be significantly destabilizing. So that's brand new, and it's still, they haven't actually released the ICD-11 yet, and there's a draft that's come out, and I think it should be middle of this year. As we've seen this probably less intensely than a lot of developed Asian countries. In 2007, it was a 28-year-old in an internet cafe in Korea. He was playing StarCraft. At that time, it was a pretty big game. For about 50 hours without essentially stopping. Hadn't been eating. Fluid intake was minimal. Fluid output also, I think, was minimal as well. And essentially collapsed. And the data is, I mean, relatively inconclusive, but the point was that from essentially heart failure from exhaustion is what they termed it as. So just to capture and I think this is on one end of the extreme, how engaging and all-consuming gaming can be. And I had to throw this in there. Outlast 2, anyone familiar with this? So, and this is real. So it's a horror-based game that when people were playing and Outlast 2 came out, that they sent so many concerns in about soiling themselves because they got so frightened that as part of their campaign, they released underscares. And they wanted to do it was a Kickstarter campaign. They actually almost made it, but didn't get enough funding. And the moniker was, when you're playing Outlast 2, number 2 becomes number 1 in terms of problems. And they had a mesh and a disposal device. But this again goes to, you know, kind of mundane things like, you know, defecation should not, you know, come in between you and gaming. The scales, so some of the challenges that they've had is that there are no consistent scales that people can use to determine a level of severity. And this is just a few of them out there. And so then, you know, how stringent versus, you know, kind of lenient do you be? With the DSM-5 criteria, which is a little bit more, I would say, on the stringent end, some of the studies looked at how if you hit about 5 of the 11 out there, you're more consistent with, you know, problematic gaming. This was a Dutch study that looked at also higher scores in essentially loneliness, aggression, which is a big deal we'll come to later, less pro-social behaviors, which also makes sense to a certain extent if you're kind of glued into a box of some sort. So prevalence, and it's been kind of across the board. I would say between 0.5 to, you know, 8 to 9% would be the range. And I think in reality, it's probably somewhere in the middle. It really does depend, again, on what scales you're using. But that's what we're seeing. There's a few things, and I'll get to probably in the next slide. Males, across the board, being male equated to higher risk of developing gaming problems, almost up to 6-fold in some of the studies that they found. Age was also a factor, but that's softening to a certain extent as more and more older, or I would say adult individuals are gaming. Depression, social anxiety, and social isolation. This was across the board something that was seen to correlate with gaming. And this makes sense. So with social anxiety, which is essentially this debilitating anxiety, you're almost kind of solely focused on negative perception of social interactions. With something that's as depersonalized to a certain extent without the physical or auditory cues, you know, so whether it's, you know, blushing or stuttering, this modicum of communication then enhances almost to a significant degree social communication. So they call it hyper-personal communication. People develop bonds much faster than they typically would in the real world because it feels like there's a no-holds-barred kind of environment. They form, you know, teams or leagues that become almost, you know, more important to you than family because you're sharing things that really no one else knows, and you're not worried about, you know, negative valuation of how you perceive yourself. And so it really kind of walks hand in hand with what gaming would be trying to achieve. This is an oldie but a goodie of the struggles that parents have had. But again, if you factor in Pokemon Go there, maybe they are safer indoors. Anders Breivik. Anyone recognize the name or the gentleman? So in 2011, July 2011, in Norway, it was an island in Norway, he massacred 69, I think, young children at a political camp. he was a self-professed fan of, and the game that he was playing was Call of Duty, and used one of their, it was a holographic aiming device for, essentially, he said that he continued to use repetitively for target skill and acquisition. So, and this sparks, and we'll get into this whole debate of, gaming and violence. With him, and the story gets even weirder because, so he still is imprisoned in Norway. In 2014, I believe, he essentially tried to sue the government because the conditions that he was being held under didn't allow him to have gaming consoles that were appropriate. The kid games, or the lack of mature games, he felt was unconstitutional. And, I think he threatened a hunger strike of some sort. And at some point, and this is a couple of years ago, they actually did rule that they were violating his human rights. And I think he did. It was a PlayStation 2, and I think he wanted a 3, and I think he got some more gaming. This is, again, an extreme case of how dangerous this could be. However, anyone recognize that's Adam Lanza? This is the Newtown shooting. Also, Call of Duty was a big, and he had a basement that had blacked out windows and was playing for several hours on end. The point, though, before we kind of rush to judgment, and I think I want to stress that one does not definitely equate to another, because they looked at, and this is on one end, and the APA, American Academy of Pediatrics, in strong wording, put out that they feel that gaming and violent gaming has a strong correlation with actual real-world violence. A Western Michigan University in 2015, however, found that if you essentially accounted for other factors, it really didn't seem as like that was a significant effect. And this is interesting, this economic study that they did in 2016, so they tracked when some of these games that are touted to be the more violent out there, when they were released, and they actually reviewed violence or spikes in violence. And as opposed to an increase, which is what people would think, there was a dip in some of the violence that people saw when these games came out, and it was kind of somewhat correlated. Would that mean, so if there are, let's see, rageful, uncontrollable, aggressive impulses that people were then using these games to release in some way, or keep people engaged, especially adolescents or people who are more prone, would be the theory, which would then again point to this is actually kind of a helpful thing to have, as opposed to people walking out, and shooting things up. In today's day and age, this is, I think, an increasingly worrisome dynamic that we live in, and I don't think we have a consensus. And so, there's really strong camps on either end that kind of vilify the other. I do think that there are some people who are prone to violence and then would be using these games as a way to maybe enhance or hone that. But it's not that, you drop a kid who, let's say, is neutral, and then you expose him to a violent game, that it would then floridly relate to then real-time violence. Still hotly contested, though. With gaming and substance use, the data is still somewhat, I would say, inconclusive. They have seen alcohol and tobacco and cannabis to a certain extent were seen to be correlated, or increased use was seen to be correlated with IGD. This is interesting. So impulsivity and issues with attention were seen as a kind of a big red flag, and this is right in line with substance use as well. From a neurobiological standpoint, they've shown in terms of the decreases in essentially the ability to maintain focus and attention related to impulsivity. The increase in dopamine in the striatum, which is what a substance does. You take it in, prefrontal cortex, and the striatum starts having these essentially surges of dopamine. In response to the surge of dopamine, the receptors in that area scale all the way back because the brain's saying, this is not what we're used to, this doesn't make sense, let's go back to some sort of homeostasis, which then worsens attention, impulse control, all of the other dopamine-related activities that are then, as a result of this, affected too. Response inhibition before we move forward, which is a big deal for both substance use and I think behavioral process addictions. I mean, it's the ability to, everyone has thoughts and urges. I'd rather be, swimming in the lake as opposed to here right now, yet you're still here and you're not bolting. And it's the ability to rein that impulse in that is impaired in gaming from what they've seen, and substance use disorders as well. Without getting into too much of the detail here, there is, and they've shown, resting state connectivity between different regions of the brain. And so without doing anything, there's communication between specific areas and circuitry. And dysfunction in these resting state functional connectivity issues are what they've implicated both in gaming and substance use as well. This was an interesting study they did it was a League of Legends group study that looked at processing speed. I'm going to skip through what they actually saw. Increased volume, and this is interesting because how do you actually test or screen for this, in a physical, biological way? The right caudate and the nucleus accumbens. Structures, the nucleus accumbens is inherently involved in any form of addictive pathology. And the correlation of this increased volume with the errors that they saw in these cognitive tests are fascinating, because then we can actually look at a brain and say this person is maybe more or less prone to developing concerns. It's that the bottom right corner is what they're looking at, the increased volume of the nucleus accumbens and the right caudate. And let's move forward. So, and this is also seen in stimulant use and gambling, or pathological gambling as well. If there is a similar disease process, then again, which is pretty cool if we can actually track over time in terms of how people, or how much people are prone versus not. So what really can you theoretically and I guess realistically do from a gaming standpoint? The studies that they've looked at, family engagement and intervention, and this does make sense to a certain extent, is the best way to in some way rein this in. You should have a sense of what your kids are playing, and kids, as opposed to not wanting to talk about anything, or a niece and nephew, if you ask them how their day went on any day of the week, I get a good, and that's it. And it's the end of the statement right there. But they actually like talking about gaming. So if you engage someone about, what they're playing, who they're playing with, how this last level went, it brings you into their world, and it softens this, I can't tell, whether it's parents or anyone from a caretaker standpoint. Ratings are key, because would you not worry about giving your 14-year-old a bottle of Grey Goose for Christmas, right? So that doesn't make sense, because there's an age restriction for a reason. So games that are, rated mature because of violence or suggestive material can be just as problematic. So when you're gifting, nephews, nieces, or kids, check ratings out. Parents, when they're buying, kids should be involved in, who is this appropriate for or not, and be part of that conversation. The idea of getting kids away from screen time is key, and I know in terms of from a pediatric standpoint they have specific limitations, which I'm not exactly sure about, but there is specific limitations of how much screen time that you're supposed to get. I think it's 30 minutes to an hour at the max a day. So set limits and then have people do stuff that is more engaging or socially engaging, outdoors or otherwise. I guess the other point to make here would be there's a lot of positive characteristics of gaming. You're improving hand-eye coordination. You're improving multiple set task switching. You're improving resilience. There are, from like a physical rehab standpoint, a lot of ways that people use gaming. And so when you're a developing child where these, the circuitry is still, pretty pliable, this can be very helpful. But as with everything else, moderation and regulation when it comes to exposure. Before we go on, any questions, thoughts, anecdotes? No? So from a treatment standpoint, there's, again, this is, still in its infancy in terms of what people have tried to use. Recognizing co-occurring mental health concerns. So HDMI is not one of the slides. I may have inadvertently pressed something. Recognizing co-occurring mental health concerns is an issue. So if you have social anxiety and there was a significant amount of depression as well. I'm just going to wait until someone fixes this for me. If you're addressing that, ADHD as well, so that impulsivity, attentional issue piece, so make sure that someone who is able to concurrently treat or diagnose what goes along with gaming would make sense. So there is data looking at like tricyclics, which are an older class but still very effective antidepressant medication. Bupropion or Wellbutrin has been looked at. This makes sense because not only from a depression and anxiety standpoint, from a inattention ADHD related standpoint, Wellbutrin has been shown to have significant effects. They've looked at CBT, so cognitive behavioral therapy. To a certain extent, it was effective. Weirdly enough, and not too weirdly, I guess, acupuncture, in some of the global studies that they looked at, actually showed good response when it came to treatment actually working over a period of time. In terms of how to engage folks, family interventions or family therapy were, and I guess we're done for today, folks. Family therapy was the most robust in terms of how much exposure and then response they got to treatment. There's a documentary, it was a New York Times documentary that looked at, I think it was called China's Web Junkies. And they have boot camps, essentially, where they send a lot of these adolescent kids who are so engaged and it's just like substance use. People are isolating, they're more irritable, they're more aggressive, and it's pretty hardcore. They drop them in, it is boot camp, and they're being yelled at, and they're running, and people are kind of breaking down and crying, and it's kind of striking to see. But the idea is they're completely removed from a digital environment, kind of from a military aspect. They foster connections between these kids and then reintegrate them back outside. What's tough with gaming, as with any behavioral process, so it's not that you're introducing a substance into your system which you can then stop. So if someone's using heroin, it's fairly simple. Stop using heroin, this doesn't make sense. With something like gaming or access to technology, where do you draw the line? How do you correlate what makes sense versus not? And so there is no all or nothing hypothesis, which is kind of what we would go for from a substance use standpoint if you've reached that area of problematic use with gaming. So they have, And when we get back to slides, in terms of retreats they have, digital detox, there's this thing called Restart, where people go to remote settings, essentially camps, where they are unplugged. I think they spend a significant amount of money, which is always a challenge. But for folks or families who have either children or adolescents who are struggling with this, it makes sense because they really connect them, holistically or otherwise, to non-digital ways of stimulation. They do camps. Go for it, Rose.
But isn't that kind of more isolation?
The idea is they're with other people, so it isn't as much internal isolation, but it is taking you or removing you from, just as residential treatment would be kind of plucking you out of your environment. And it can be isolating, as is gaming or problematic use as well. But the idea is they kind of jumpstart the process there and then slowly reintegrate them back. But all of these do not occur in a vacuum. There's usually a good core of people, and it's set up, just like our typical substance use facilities. So, houses for men or houses for boys and girls. A whole campus that everyone's recognized that connection to media, and this broadens it from gaming to just media in general. Anyone's familiar with the phantom buzz? So when you have your phone in your pocket and you feel that it's vibrated and you're sure that it did and you pull it out and it's not, this is that level of awareness that's almost distracting you from kind of other things around you, because with how plugged in we all are to emails, texts, buzzes, and I can scale through at any point if you need me to, in terms of where to get.
Yeah,
We're all the way down.
okay.
Well, we definitely did under scares. Anywhere around there, and I can flip through.
Perfect. I'll just let you. Turn
Sure.
that off. Oh, actually, let me actually put it up on the thing. Sorry about that.
Not at all. So, how are we doing on time? We've got some time. So, and this is what we would focus on in the latter part, in terms of medication options. Low-dose naltrexone is a somewhat novel option for behavioral and process addictions, and I think pretty fascinating stuff, but we'll get to that. This is what I was talking about: restart your life. Digital detox is the other big one, and it's got a lot of kind of media play as well. What we can do from a research standpoint is there has to be more, as opposed to epidemiological studies, which aren't the best when it comes to figuring out a new disorder. So, real-time field testing with not only disordered people, but high engagement players. Because there are individuals out there who this is their way of life and the way to support themselves and their families. It is a high-paying field, and people do very well, and are rightfully so proud of their achievements. And so, how do you correlate that in to what we are, or what we may deem to be a disorder? There's a definite cultural influence to this. There's talk about how we really are not as I would say kind of far ahead or advanced when it comes to high-speed connectivity and access to, from a digital standpoint, media and ways to game, as opposed to some of these Asian countries. And so maybe that's played a role as well in terms of how they seem to have, from an incidence and a prevalence standpoint, significantly higher rates. The challenge of not having one consistent tool from an assessment standpoint, and that makes sense. We don't have it unless there's a consensus. We're going to be getting rates across the board, and this is some of the pushback against the ICD-11 inclusion of gaming disorder, because we're not quite there yet. again, their stance is, if we at least do this, we get funds to actually further development of research and so on and so forth. That was a slide from before. But going back to limitations of criteria, when we talk about preoccupation or obsession with gaming, if you pick a relatively, let's say, mature individual who has a football league or a fantasy football league, or their games or teams that they're following, that's all people are talking about. You're talking about who won, when, who injured what. This is something that's always part of the vernacular. It increases engagement from a connectivity standpoint. It's something people like to do. People like to track. They get together. They talk about games. Is that necessarily then problematic for kids to be thinking about games or looking forward to their next game? So kind of dangers of pathologizing there. The other limitation, one was giving up other activities around you for gaming. From a developmental standpoint, part of growing up is transitioning and shifting focus. So what interests you from a Little Pony standpoint at one point may not necessarily hold true a few months or years down the line. So keeping that in perspective when we're talking about shifting priorities would make sense. The other piece is, gaming to relieve negative emotions. Who doesn't do, or book a spa visit when you are, stressed? Who doesn't have ways that one goes to when you are rightfully, irked or furious about something to relieve tension? And if gaming is one of them, is that really so problematic? I think, as with all substance use or behavioral process addictions, the key is, continued consequences and an inability to have control. You're trying, this doesn't make sense, you're trying to pull back, you can't. There are things that are kind of falling through: relationships, careers, less so careers when you're younger, and this is another thing that they talked about, because kids are in school and they've got to manage academically, but it's not like they're supporting other individuals, so some of the significance of that is softened. But with those hallmarks, I think we can make a case for there is a section of this population that does have concerns and it should be addressed. But a large majority of people enjoy gaming and will continue to enjoy gaming in a healthy way, as is the majority when it comes to things like alcohol, increasingly now cannabis, and that's a whole other few hours in terms of a lecture. But those are things I think that we have to be mindful of when we're talking about diagnostic and pathological criteria. Any thoughts, questions? I thought this is a good time to kind of break as well. Yes, ma'am.
I have a question about acupuncture.
Mm-hmm.
Do we have research? I love the idea of seeing somebody with acupuncture for treatment of anything. Do you know acupuncturists in Jacksonville who know where to put needles to treat any of these obsessions?
We are, again, not as advanced when it comes to the rest of the world, I think, with recognizing acupuncture. If you're talking about specific, let's say treatment recommendations of do this acupuncture for this disorder, I don't think we're there yet. However, intra-auricular acupuncture, anyone familiar with? They've used that from a detox standpoint, and this is, you've got from some fortitude required when you're actually taking people in and you're saying no meds, but it was actually fairly effective. And that's how, from a biological standpoint, we can see that this makes sense. In terms of live testing data from the US, I don't think we have enough to clearly treatment match in terms of specific procedures, but everything I've seen, and that's pretty broad, has shown a positive effect with acupuncture. It's not maybe, you know, significantly robust for all conditions across the board, but that is, I mean, I think it's an area what we are missing out on and that we need to focus on. It's picking up steam, I think, to a certain extent. Yes?
So you mentioned there's kind of evidence to support that it increases violence and evidence that it maybe reduces it a little bit. What's your thought on that?
So if there is a recognition of an individual who tends towards isolation, has concerns from a, you know, if we go the personality route, you know, complete lack of empathy, you know, if, you know, quote unquote, you know, antisocial traits that we're looking at, from a, you know, a childhood standpoint, things like, you know, setting fires, you know, violence towards animals / other people, that's when I think this becomes a bigger red flag. It's tricky because if we were to put a blanket, you know, kids don't play games, across the board, violent games should not be part of the vernacular at all. And the whole point there is, just as with substance use, you know, why is there an age limit? Because your brain is still developing, and you know, your frontal cortex to have the ability to put the brakes on, you know, uncomfortable or inappropriate urges or impulses, they don't have that as a kid. You know, delayed discounting, which is essentially, you know, holding off on something with immediate reward, knowing that there's a better, more consistent reward, like up ahead, a few months away. Kids or teenagers don't really have that well formed. And this is where, you know, from a driving perspective, this comes into play as well. So if you're introducing substances or data that is going to influence them in a way that is negative before they have the ability to regulate, you know, you're looking for trouble anyway. So first thing would be exposure, and at what age. But after that, it really is individualized to what else is happening around this person for us to be able to say that, you know, this doesn't make sense. I don't think, you know, from an authoritarian standpoint, one can just go and kind of nuke all the violent games that are out there, because it does serve a purpose. Uncomfortable, you know, people who have aggression or rage in some way, kind of having an outlet does make sense. There's nothing, even though there is some strong wording out there for us to say, again, that there's causation. You know, you take someone who's neutral, you get them playing something that's violent, they then go and, you know, perpetrate that violence in some way. I don't think we have anything out there that indicates that. But it's what surrounds that individual, I think, that's more important, and then, which is always the case, more nuanced kind of directive recommendations, if that answers your question. Yeah.
I totally agree with that, because on the one end, there are the negative consequences for the people who are prone to those kinds of behaviors, but on the other hand, there are some younger kids, at least that I know, that could possibly have some social disorders, maybe be on the autism spectrum, and it creates ways for them to socialize that they wouldn't.
And that can be a good thing, really, for people who are so shuttered within their own rooms, and this terror of actually walking out and interacting with people, which then enhances the isolation even more. Things like, whether it's, you know, media or gaming in any way, does help people build relationships. And I've had patients who are younger talk about these people like they were living, breathing individuals, and they are. We presume they are, but with as much warmth and joy as someone would get from another relationship. So, as with anything, though, there's pitfalls to that as well. Anonymity can kind of really limit your ability to actually be certain of what you're actually doing or who you're actually talking to, but it can be very helpful too. Okay. why don't we, I appreciate everyone actually is awake and I think relatively engaged. Let's take a break maybe and then come back in a few minutes. Thank you. So before we get to naltrexone, and I always think this is really interesting, just from a historical standpoint, just looking at opioids and how we got to where we are, not necessarily also from an epidemic standpoint, but just from a biological understanding of receptors, without getting too intricately involved in detail. That is the poppy plant and the poppy flower, Papaver somniferum, and so pretty hardy. It could withstand a fair degree of variance from a temperature standpoint. The blooms don't really last that long. The seeds don't do too much from a psychotropic standpoint. However, and this is where humans are ingenious, at some point, someone thought, let's take these pods essentially and crush them. And initially they mixed it with a little bit of water, and people felt good ingesting it. The sap that you can see there, they hardened it, and then as with the adage is one can smoke anything, they tried smoking that, and it was intensely more pleasurable. And this is where, in terms of smoking opium, this was when they first discovered how profoundly psychotropic the effect was. There are, from a hieroglyphic standpoint, they've found pictures for gil, essentially, which was joy, within the translations that they've picked out. And that it looks essentially unmistakably like an opium poppy. And this is several thousand years ago. From a Greek standpoint, and I'm going to move forward, the Greco-Roman fascination is well documented. Hippocrates used, amongst other medicinal characteristics of other plants, opium was pretty high on his list of, it was almost a panacea at that point. The decline of the Roman Empire, who really did engage in a fair amount of opium use, was in the 500s. With that, their trade routes kind of dissipated, and it shifted to the Arab world. So Samaria, which is Iraq essentially today, is where a lot of the cultivation boomed at that time. Trade routes, India and China were big supporters and purveyors at the point. And from a religious standpoint, with the Quran being completely anti-alcohol and it's prohibited, so opium and hash use really picked up steam. And this is where, from a trade standpoint, opioid use or opium use at that point picked up. Surgeons at that point, and this was quite non-specific, they used a sponge and they soaked it in essentially an opium liquid, and they would kind of mop people when they were doing surgical procedures as a way to dull pain. You're clearly not titrating or calculating anything, and so you're shooting the mark, probably, not even in the same building that you want to, but at that point they were able to really get in, and from a procedural standpoint do so much more from a pain control benefit that they got from opioids. But again, you couldn't really calculate how much you were using. The German pharmacist that first isolated opium's active component and then essentially termed it morphine, which is based off of Morpheus, the God of Dreams. I hear Morpheus, I see Lawrence Fishburne in Matrix, which I think will always be linked. From this, we got to diacetylmorphine, which is what we now know as heroin, which is also derived from the German word for heroic. And interestingly, and we should have seen this right then, there was a pharmacy company or pharmaceutical company that titled that as well. Receptors, from a discovery standpoint, were huge. At that point, in terms of how substances interacted with the human body, Um, Moving forward, so which we will be focusing on, opiate receptors are G-coupled receptors. So basically they are typically inhibitory, but they're also similar to some other receptors in the body, and we're going to focus on these toll-like receptors, TLRs, which are involved in inflammation a little bit forward. From a activity standpoint, and this was what was fascinating for scientists at the time, that they found, you could activate a receptor, you could block a receptor, you could kind of do something in between, and different compounds reacted differently to these specific receptors. And so agonists, which fully activate, a partial agonist, which makes sense, it's kind of the door is half open, and antagonist blocking. You guys have maybe heard of the lock and key hypothesis, which essentially describes what we're talking about. It either connects completely, blocks it to a certain extent, or kind of opens it and then just leaves it kind of cracked halfway. And this is important from a pharmaceutical standpoint as we move forward. It's not as simple as just this pure lock and key diagram, though. They are three-dimensional. There's different sites on all of these receptors that different molecules attach to. And this is enkephalin. So, I mean, this is an endogenous endorphin. So, opioids, essentially, that we create within our own bodies. And they have, again, different sites that bind on these receptors. So, methadone, which was one of the first, the first synthetic opioid that was essentially discovered and then manufactured, is a full agonist. There is no ceiling to a certain effect when you're keeping on using methadone. Buprenorphine, which Suboxone is buprenorphine with naloxone, does have that same activation of mu receptors, but there is a ceiling effect, which is why theoretically they see this as less risky from an overdose standpoint. And something like naloxone or naltrexone, there is that complete blockade. With what they found naltrexone could do, and it was a compound that they came across somewhat inadvertently. This was fueled by first morphine, and then with World War II, and then people having difficulties getting enough morphine from a battlefield standpoint, they started to try and find, how can we synthesize this in a way that's artificial or otherwise to be able to address the needs of combat and war. And so they found this compound that mysteriously essentially counteracted the effects of morphine initially, didn't know what it was, yet found that there was a role for this, and this medication eventually was naltrexone. And so once they found that this was completely, from a blocking standpoint, effective, and with the burgeoning use of opioids, it was in '84 that they first licensed it for treatment. Now, the challenge here, so we have opioid receptors through our system. With whether it's opioid use or overuse, receptors are not static. They are fluid, and they respond to, how much is being used, how potent the substances are that you are using, and also blockade. So, you block someone's opioid receptors, it's not that they remain at, from a tolerance standpoint, what they had been using before. Receptors that have downregulated, upregulate back up. And so the danger that they found was, although naltrexone is incredibly effective and incredibly uncomfortable to a certain extent as well, because it blocks someone who's been on opiates, which is why there's always a window period, when people stopped using it and returned to using, their tolerance and threshold level had significantly decreased, and vicious cycle of people using, overusing, overdosing on opioids coming off of blockade. The idea was that this can then be linked up with enough treatment over a period of time for people to be able to use, kind of a wraparound coping skill mechanism to help with, because addiction is not purely just about the pharmacological effect. There is an entire world of characteristics that, that are associated with it. The Sinclair method, anyone familiar with or has heard of? So this was John David Sinclair was initially worked, I believe, it was in New York before he kind of focused in with the Finnish National Institute. Used naltrexone as a way to essentially extinguish the reinforcing effect of alcohol. So at that point, the idea was it's not that you take it daily, but you take naltrexone an hour before you drink, and the idea was pharmacologically essentially extinguishing this behavioral pattern that people who were identified as, at that point alcoholics or having alcohol use disorder. And this was a huge movement because really the holy grail for anyone with a substance use disorder is, how do I get back to using in a way that isn't, destroying my life? And there is, and there was, some efficacy to this, to where people were able to take this dose, and then over time they found from a pattern standpoint that they potentially could drink less, because the naltrexone is blocking the endogenous opioids that are then kind of surging through your system, and the pleasurable effect of continued drinking then gets kind of minimized over time. And so there's a behavioral standpoint as well. This, however, from a medical model standpoint, does not necessarily, I think, hold weight. And the idea that if one has reached that level or that tipping point to where you are, somewhat, from a control standpoint, not really in the driver's seat anymore, to this date, at this point, from the data that we have, we don't have anything that suggests that from a receptor pathway overview that we can switch back to how one had reacted to substances before. There's a lot of people out there who still do this, and from a European standpoint, they use it, I think, a lot more than we do here. Chirality is, and this is a big deal from handedness, and this essentially means that receptors can have two mirror images, essentially, just as we have a left and a right hand. And if you're looking at molecules out there, you can see how, even though they're essentially the same structure, they are essentially reversed. And this is a big deal because how molecules react to receptors, chirality makes a difference too. So there's a left or a right isomer. So most of the drugs on the market typically should, for the most part, have an equal quantity of left and right isomers of any medication out there. And this is where, regulatory mechanisms, make sense, because this is where they're supposed to be at. However, there is a clear difference, though, between left and right. So with low-dose naltrexone, what the dose of naltrexone that was FDA approved in the 80s was a 50 milligram oral dose. They tested all the way up to 300 milligrams, and the few reports of liver-related complications typically occurred on those higher ends of the dosage range. But a 50 milligram dose taken orally, typically taken daily, provides a significant blockade of your receptors that lasts presumably through that 24-hour period. So, what is the difference and what's the big deal? With low-dose naltrexone, you're actually shooting for between 1.5 to 4.5 milligrams of naltrexone. And it's not timed released, and so the point is it is a short, time-limited blockade of the opioid receptors that is then excreted and metabolized through your system. To kind of simplify what happens, so it kind of attaches to the receptor. the body senses, and what we're looking for at this point is this opioid growth factor and the growth factor receptor. And naltrexone binds to these receptors, and opioid growth factor is implicated from an immunological standpoint across the board, and essentially all the cells in our body have these receptors and respond to opioid growth factor. What happens in regular dose naltrexone is that you're getting this blockade, the system senses it and realizes, wait, something's off. I need to be producing more. I need to be increasing the number of receptors to counteract this perceived block, which does happen with regular dose naltrexone as well. But despite this kind of upregulation, the blockade is still in effect, and you're not necessarily seeing any effects, let's say, of what your system is kind of doing as a compensatory mechanism. And this is the crux of what low-dose naltrexone does. So it occupies it, and they call it the kiss and run theory, which is in no way something that we recommend in general population of running around and kissing people. But what we want to do is jump in, they feel the blockade, they start revving up the troops, and then it's excreted and metabolized out of your system. So then, by virtue of it now being unblocked, you can actually experience the benefit of having this increased, essentially, opioid growth factor that's kind of being upregulated. So early 80s, it was Dr. Zagon and McLaughlin that were at Penn State University, and then Dr. Bihari, he was an internist in New York City in the 80s, and he had a burgeoning HIV practice. And this is kind of right when there was a surge at that point. He first tried it out with a multiple sclerosis patient that he had, just to see, because and there were talks of how this could be, immune related way back when this was first started, and found, and this was again an isolated case, but he found an actual anecdotal, let's say, response to low-dose naltrexone. So he identified, a pretty significant sized patient population with HIV, and started using low-dose naltrexone. Had a control group as well. CD4 levels are, and this is still used in terms of how you track how someone's doing from a disease standpoint, and found across the board in terms of not only CD4 count, but consequences, other opportunistic infections. So what happens with HIV/AIDS, right? So your immune system is shot. You're way more prone to being infected with things that someone with a normal functioning immune system wouldn't. And he found a pretty significant benefit from a small sample size, I should say. But this kind of kicked things off. And I would say the three of them started up this kind of LDN movement at that point, which has come significantly, and I can let you know where they are right now. Moving forward to what we talked about, how they're similar to these toll-like receptors. So long story short, TLRs are essentially what get into gear as a way to combat and defend external invasions in your body. So you're essentially white blood cells, all these neutrophils, B lymphocytes, essentially are your military parade that's activated when you've got like a pathogen that's in your system. And the TLR, the toll-like receptor, is implicated here. What they found is an NF-kappa beta. So NF-kappa beta is one of the other compounds that essentially activates cancer oncogenes. So cancer is uncontrolled cell growth where it's not supposed to be growing, which the NF-kappa B has been implicated with. And this is also highly related to toll-like receptor activity. So again, from a whole, like a standpoint of what this does is it kicks up an inflammatory response. What they found was not only from an opioid standpoint, right? So it's occupying these opioid receptors and therefore kicking off essentially this upregulation in your own endogenous opioids. It also connects with and interacts with a whole host of toll-like receptors, and there's, I think, 1 through 10. They're not really clear about all of them, but toll-like receptor 4 is a big one from an inflammation and a pain standpoint. And what this does then is essentially blocking the inflammatory cascade from happening, which is, I mean, striking if you look at how significant that is. Over the years, and so, you know, why don't we know about this more, right? If this is such a big deal, and I'll go through all the diseases that it's been used for, and it comes down to money, right? So there's no money in really promoting, or from a pharmacological standpoint, a medication that's been around for decades. So the LDN movement, and they have a nonprofit organization that's global, has essentially been spearheaded by patients with their experiences and physicians who can prescribe this, and we'll talk about how, as essentially getting the word out there as something that, from a risk-benefit ratio, is pretty significantly stacked towards a beneficial standpoint. I mean, you're using an FDA-approved medication at significantly lower doses, therefore less side effects, yet you're kind of employing your own body's immune and other related systems as a way to kind of fight back. So homeopathy is different, right? So then we're going to microscopic dilution of these compounds, and which is a whole field in and of its own. But this is completely different because even if it's a low dose, the response that it gets is robust and profound. So someone on opioids, you know how you should never give a blocker because you're putting them into instant withdrawal. You will have withdrawal with even low dose naltrexone because it attaches, and the affinity for the opioid receptor is pretty big. It doesn't last as long, but it clearly has as much of a powerful effect as regular dose naltrexone. So these are the published trials that are out there right now in terms of what's out there, and then we can go more into, from a mental health standpoint, the depression piece is key. PTSD is another disorder, I should say, that they've found significant help with. And this are published case reports and series in terms of what it's been helpful for. Now, I think anyone would be skeptical when they see this because, how is this one medication really that helpful for this many different, and I will say it is not a magic bullet in any way, but the thread of connectivity from an immunological and an inflammatory standpoint runs through all of these conditions. And the idea, even if it's not this miraculous cure, it can be used adjunctively with medications that are out there to reduce the dosage that you require, the number of meds that you require. I mean, we should, from a medical standpoint, always be streamlining how much someone is on because of side effects and long-term adverse effects. And they found that using this adjunctively, not yank everyone off their regimens and just put them on LDN, but how effective it could be in conjunction. And these are what's out there from a patient-reported standpoint. Going back to what we had talked about from a left and right isomer standpoint, we found now that the levo and the dextro isomer of naltrexone has different effects. So with the levo antagonist, you get the opiate endorphin activity that we talked about, and the dextro gives you the TLR activity. So you want to make sure, again, when you're using a pharmacy, and that's the next point, regular pharmacies don't have low-dose naltrexone because all they have is FDA-approved 50 milligram doses. You need a compounding pharmacy, a pharmacy that's able to essentially do everything that they're supposed to, but specifically design medications at a dose that you want it to do. And there are a few identified across the country that are good at what they do. We use one in Aurora in Illinois, and who are phenomenal. And the idea that everyone should again remember is it's not time released. It's got to be short-acting naltrexone because you do need that quick occupation, and then it has to be out of your system. It's not as, go for it, Rose.
And is Alkermes do that, or is that just Vivitrol?
Alkermes is just Vivitrol. So these are really independent organizations that are compounding pharmacies. A lot of them are like family organizations that have been around for decades, but very efficient at what they do. Some of them do, so something like Vivitrol, and it's, again, it's all about, you know, patent and money. They could theoretically develop long-acting naltrexone, which I want to make sure everyone knows. So Vivitrol is the injection you get that lasts essentially 4 weeks, that blocks, you know, your opioid receptors for opioid use disorder and alcohol use disorder, but it can only be purchased essentially from Alkermes, who markets it. These compounding pharmacies can do exactly that, but they would be in a whole world of pain if they did, because, I mean, from a legal standpoint. There is no illegality, though, when it comes to low-dose naltrexone. I mean, you're using it at for an off-label use at a lower dose, but, I mean, it's completely sanctioned. You should know, again, who you're working with and what you're getting, and the idea is you work from between 1.5 to 4.5 milligrams. It is fairly reasonable from a cost standpoint. So 30 caps of let's say a 3 milligram dose is between $30 to $40 for a month. They typically, most compounding pharmacies don't take insurance, but they will, you know, give you receipts to be able to be reimbursed by insurance. And so one automatically would think, wow, if this is this design drug, this is going to put me back, you know, millions. But it really is fairly reasonable, and especially when you have people who are struggling with a variety of these illnesses. Pain independently, yes, go ahead.
I just want to make sure that I understand with the naltrexone, it will bind to the NF-kB receptor side.
It's the toll-like receptor that it bonds to, and then it antagonizes it. So essentially blocks the activity of that receptor, which would be increasing the NF-kappa B, which is then implicated in, you know, cancer oncogenes and silencing them. So we want to kind of pull that activity back, which is what the naltrexone will be doing from an immune standpoint. It's blocking. Just anecdotally, there are people, chronic pain that we've treated who, with this low-dose naltrexone, I mean, these are people on significant regimens who've been able to scale back to, you know, Tylenol and Advil, which is pretty phenomenal. It's a binary response for the most. I mean, sometimes people take it and it's pretty striking over not too long of a period of time, and sometimes they're like, this doesn't really do a whole lot. So be it. It's worth a shot, and you kind of move on. But again, something that awareness will help, because there aren't a lot of physicians who are either aware or comfortable with using meds. But if you look at it from an off-label use, everyone everywhere is prescribing stuff for off-label use that isn't quote-unquote FDA specified. And, you know, in that spectrum, something like low-dose naltrexone really is towards the lower end of a risk pool. And without going into all the other diseases, and I thought depression and mental health would be something we can spend a little bit of time on. There is the common conception that, a lot of the times, especially with chronic illness, and a lot of providers are guilty of this as well, because we use our own experiences as almost fact. When we say, this is happening, you've been in the hospital, you had a surgery, it sucks. You feel bad, everyone feels bad, you'll get over it. And people sometimes skate over the correlation with chronic medical illness and there being a very true depressive element to what they're going through. And there are differences between what someone would look for and expect from a purely medical illness related standpoint to when, depression comes into play. Because, there is this quality of your self-esteem, essentially depleting. You have negative self-perception. There isn't a situational aspect of, yes, this is something that worries me, but I'm able to enjoy, these other spheres of my life, that really do, for the most part, escape a lot of physicians from a medical standpoint. And the idea is, if we're not seeing depression as a biological illness, just like someone going through, knee replacement surgery, we're kind of missing the boat here. What we've, found with LDN is using it in concurrent use with other medication regimens that people use from an antidepressant standpoint, anxiety standpoint, would again affect the lowering of dosages that people use, because all of these meds, including naltrexone, have side effects. And so our goal is not that LDN can again, swoop in to be, the savior of all, but that it can really enhance someone's not only personal experience, but also kind of limit the pharmacological regimen that they're on. Extinguishing unwanted behaviors, they kind of now use, with Sinclair's method, remember the regular dose, an hour before you started drinking, there's a lot of practices that now use LDN like that. Essentially tying this into compulsive unwanted behaviors, whether it's, sexual compulsivity or gambling, and using it with psychotherapy and medications as a way to essentially, from a behavioral standpoint, that rewarding element that people get, the surge that they're looking for, is attenuated, and over time, that becomes more the norm. Just a note on, this is a theory that they've put out there, the endorphin deficiency of people who maybe inherently just don't have the ability to produce the endorphins that we all produce and we kind of take for normal. So these are people who, are very sensitive to changes around them in the environment. They're kind of almost brittle to a standpoint of, too much stimulation, too much change is almost perceived as pain and distress. With folks like this, they typically have immunological issues as well, which makes a whole lot of sense with everything that we've talked about and how the opioid system is connected to your immune system. And from a treatment standpoint, something like this then fits right in with what we would be looking for LDN. Boosting your body's ability to create and produce more endorphins. A quick note on just the receptors that we have, and some of these, in terms of what we have endogenously, would be endorphins, enkephalins, deltorphins. Those are the three main receptors, mu, kappa, and delta, that we have. We can, and I just want to focus maybe on the mu right now. So from an opioid standpoint, what people are targeting or drive their use is the euphoria that, the activation of mu receptors afford them, which also unfortunately though goes with, sedation and respiratory suppression, which is what we see from an overdose standpoint. The kappa receptor is a big one. from a connection with depression, anxiety, and specifically stressor-related depression, anxiety. And so when you're in withdrawal, your kappa receptors are overstimulated, essentially, which is what we try and quell. Naltrexone blocks that. So it's not only blocking the occupation of the mu receptor so that opioids can get in there, it's dampening the withdrawal that one feels by overactivation of the kappa receptor. Delta receptors are good from a standpoint of if we activate them, they actually help in terms of decreasing depressive symptoms. BDNF is a big deal. I want to move forward to this. Brain-derived neurotrophic factor. Anyone familiar with this? Anyone has heard of this? I think this is really going to become a target. It already is, of what people are looking for. The idea is, so it's a molecule that's protective for the brain, and essentially the lack of which equates to more prone depression. They find in, with childhood trauma, BDNF levels are decreased. Without BDNF, you get, so as in depression, you get hippocampal atrophy. So this is seen as a protective agent. There are a lot of things. So exercise, cumin from a cooking standpoint, turmeric increases it. Intermittent fasting, I can see Dom's perking up right there, does increase BDNF, and LDN does show increased BDNF levels. And this is something I think that they're really going to target in ways that can be protective to one's brain, depression, trauma, so on and so forth. Recent news before we wrap up. So, and I would say the bigger, so with all of this that we have, it's still really not gone anywhere, either here or worldwide. Nigeria was the first country in 2016 to officially approve it for HIV. And this is just recently in March that the FDA approved essentially a phase 3 trial specifically for Crohn's disease, and Immune Therapeutics is the one that's kind of running that. So the idea is that this is, I think, building up steam over time. But with the lack of funding involved, which I think is the main limitation, it may take a little bit more. I'm actually going to smooth past that because I think we've talked most overly whatever else we've discussed. Options and questions or comments, complaints?
So, with Vivitrol and Suboxone and all that, you have to go to psychiatrist for low dose naltrexone. Same.
It's any physician who can prescribe can send in a prescription for low-dose naltrexone. The idea would be, ideally they should know, what it entails. You do have to directly contact a compounding pharmacy, but that's it. There is really no other regulation or specifications. For the most part, though, if you randomly kind of walk in and say, LDN now, or I walk, people are going to balk at it because if they're not familiar with it. LDNscience.org is the, and it's on my references somewhere, is I would say the biggest conglomerate of both providers and information out there, and they've got all the data on what's being looked at. They do have a way to connect you with physicians who have identified themselves as LDN providers. So, that could be one way that people can find ways to get it prescribed. Yep?
Are you currently treating adolescents with low-dose naltrexone?
I personally am not, but I know that they are. I don't think that there is, from a pediatric standpoint, concerns. One has to, again, make sure from a dose level standpoint, you're not exceeding things. However, the benefit of what this is, so, rule of thumb for kids is lower doses over a longer period of time, right? So you don't do full adult doses, or you say they're not viable to use this at all. That we get away from some of that because of the low dose that's already being used. There should, however, be a conversation about what's being treated, and this by no means is first line. And so first line treatments, usually it's people who are either treatment refractory or who are really struggling that would go down this route. And I would say with kids, that's probably what you want to do with the complexity that comes with children. But it is being used out there. Personally, I have not yet, though. Okay.
So you said it works for inflammation. Does that also include like lymphedema?
Yes.
I didn't see it on the list, but I know that's kind of
It could theoretically, if there's an inflammatory process that's causing the lymphedema so there's obstruction and a buildup of lymph somewhere. If there is an inflammatory process, it should. I'm not sure if there's, again, a lot of data with that. Theoretically, it should. I also do want to, from an inflammation standpoint, there is a growing school of thought from a mental health standpoint that, depression is inflammation related, and it is also an inflammatory process, which again makes sense from what we are seeing with low-dose naltrexone and the blockade of these inflammatory cascades that get kicked up.
With the compounding pharmacies, how are they regulated and how are they located?
They are not as, I would say, commonplace as your regular pharmacies out there. With going through either ldnscience.org or lowdosenaltrexone.com, they connect you with sanctioned pharmacies that they've worked with. The regulation that they have is essentially internal regulation, because this isn't an FDA-approved use, and they do a lot of other meds as well, which go through the same stringent processes. But this is where vetting becomes important, because anyone who paints a sign and says we are our compounding pharmacy should not be utilized without appropriate vetting. That being said, they use the exact same strategic procedures that are in place to enhance quality control. They're few and far between, though, and so which is why people use the same few tried and tested ones, because of consistent efficacy. But they're not FDA approved. So regulation is, from a contrast standpoint, one could poke holes in its efficacy. Yes, sir.
You mentioned in your Crohn's disease, is it used to decrease pain associated with it? Or
It's pain and in terms of active disease, so there's a strong inflammation component when it comes to whether it's Crohn's or ulcerative colitis. And what they're saying and what they're trying to do is scaling back that response. By virtue of which you get pain relief, but it's more addressing the underpinnings of actually how this is an immune deficiency or dysfunction, that the theory is that that's what it's actually working on. But pain does improve as well.
are you aware of whether Mayo Clinic here is?
I'm not. There are a lot of pain clinics that we've worked with, that I know of in New York and in Chicago, that do use low-dose naltrexone. Specifically about Mayo here, I'm not sure, but it is part of their regimen for, I know some people with chronic regional pain syndrome, CRPS, that it's something that they pull out when they really, typically people go through all your first line, second line, third line, and when it's really not improving in a way that they'd like to, or someone's on 17 different meds, is when they try it. But it is From a pain clinic standpoint, some of them, I would say the more savvy of them, are using, sparingly low-dose naltrexone.
What was the name of that website?
ldnscience.org. And it should be on the references page as well. Yep, Rose.
So if you were to try to use naltrexone for any of those maladies that are on your list, and it ends up not being the right fit for the symptoms you're having, you don't necessarily have that many bad side effects from it, right? Other than maybe nausea?
So GI side effects would be the most commonly cited ones. So, queasy, upset stomach, whether you're on the loose stools versus the constipation side. Sleep disruption sometimes is seen. So earlier on, they used to say you should only dose it at night because they wanted to time that spike in the 2 to 4 a.m. kind of period. And so it's synced with your circadian rhythm as well. However, they did find that some people, by virtue of, we really are upregulating endorphins within your system, and they could find that this is difficult for them to kind of tolerate from a sleep standpoint. And they have found now that people who dose it even during the daytime, you still can get the same beneficial effect. So for the most part, it's GI side effects, some sleep disruption. Some people, and I should mention, from a thyroid standpoint, if people have like Hashimoto's or essentially hypothyroid, so thyroid's not functioning, they need supplementation of thyroid. You give someone LDN, their immune system could really kick into overdrive to where they won't necessarily need the thyroid that they're being supplemented with, and that shoots them into hyperthyroidism. So you've got to be careful with scaling down your thyroid supplementation if you're trying it. Other than that, although I'm sure there are anecdotal responses of people, because you're tweaking a chemical system that is profoundly connected with emotion, joy, fear, unhappiness, and so there may be instances where, people do feel, whether it's distress or dysphoria. It's out of your system in a matter of hours, though, so, and this is where, if it's tried, either it doesn't work, you don't feel it, or if it's uncomfortable, you stop it, and there really are no lasting negative side effects. Yep.
How would it work for treatment of the resistant depression?
Treatment-resistant depression. So the idea with treatment-resistant depression is, given that when you qualify for treatment-resistant depression, you've failed multiple medication trials, right? And so the meds that we have out here right now are either serotonin-related, which was the first kind of focus that people were going for, things like Lexapro or Zoloft and meds like that. Then they realized from a theory standpoint, and this was that last slide, that didn't necessarily, it wasn't the magic pill that people were expecting. So clearly there's other routes. So the dopamine route, which is heavily implicated from, an opioid receptor standpoint, again, the surge of dopamine that we get, is what they tried to address with combination meds. So things like Cymbalta or Wellbutrin looked at trying to enhance through norepinephrine, getting an enhanced boosting of dopamine. What LDN would do then is, treatment-resistant depression, they'll be on, a regimen of medications that may be suboptimally effective. You add LDN on as a way essentially to boost the effect that they would get from a dopamine standpoint. It's not purely serotonin related, but there are studies that show that cells pre-treated with dopamine respond better to serotonin. And so through that route, they found, or they theorize, that you would respond better to a serotonergic medication even if we aren't targeting serotonin directly. So as a treatment for, treatment-resistant depression, the idea would be you add it on, and with enhanced psychotherapy and perhaps even lower doses of the medications that you're currently on, you can see some benefits. Which again, this is more isolated in terms of people who are using this, but they do find that it helps. Yep. With psychotropics, yeah, you would add it on to the regimen. So you wouldn't take them off what they're on and then put this on instead. It would be something that you could add on and then track for improvement, and then perhaps be able to scale back or not, depending on where someone is. This is by no means the only route out there. There's things like, transcranial magnetic stimulation, ECT. These are all, highly effective, evidence-based, interventions that are out there, which have the benefit also of less side effects, because if it's not medication related. But again, with something like low-dose naltrexone, the thought is you're really trying to limit a side effect profile by virtue of its action.
Are there any active trials with this particular medication in the treatment of cancer?
Absolutely. There's actually a variety of cancers. So remember the NF-kappa B that we had talked about, which is essentially silencing cancer oncogenes, and these are the patient-reported ones. And I remember lung cancer. There's also esophageal and pancreatic. Where's pancreatic? Pancreatic cancer is a big one that they've looked at. Colon cancer for sure, which fits right into this whole method of essentially blocking this uncontrolled cancer, which is cell growth where you don't want it to happen. And yes, so absolutely. Mm-hmm.
But that would be earlier, probably, in the treatment of pancreatic cancer, not like in the.
Not necessarily. Again, I don't think this is going to magically reverse, especially with something like pancreatic cancer, right? So, which is so it's tough. It really ramps up its activity fairly quickly. So, if you're not catching it early, it does, limit efficacy for sure. But the idea is getting it on whenever you can, and if there's a way, if not to reverse, but at least slow progression. All right, folks. Right on time. Thank you, everyone. Have a good rest of the Friday and the weekend.